مساء الخير جميعا. This is just I'm starting a bit early just as a trial to see if everything is working. So don't go away. I'll be back in a second. I'll just check if everything is working. Okay, here I am again, and apparently yes, everything is working. So how have you all been? Hopefully not too bad. That's promising. I can see the number of people tuning in increasing, so that's good. This really feels like just beginning of the lab or the lecture where I'll be waiting for the students to come. Feels very, very familiar. Just give it a couple of more minutes and then we can start. Okay, here I am again. Can you all hear me? I hope you can. Um, I would appreciate a comment just to show me that you guys can really hear me now. Okay, perfect. So you can all hear me. That's so good. Maybe I can start now. Um, my name is Rami Farah, and I'm a pediatric dentist, currently working in private practice and also teaching part-time basis at the University of Jordan. Before that, I worked for a few years at Johns Hopkins Aramco Healthcare, and before that, I was a university lecturer at the University of Otago in New Zealand for quite a long time. And I promise you, I usually am much more handsome. This is just the work of the quarantine. Yeah, what can we do? We're all in this together. But I also promise you that this will be an amazing lecture because today I'm wearing this, which is the tweed jacket for amazing lecturers, just like Indiana Jones and all other American movie university lecturers. Okay, jokes aside, I would like to thank Jazz in general and Diyar Al Qawasmi in particular for making this happen and for inviting me to present this talk. And this talk about molar incisor hypomineralization is something that is dear to my heart because I spent most of my career and both my doctorate degrees at the University of Otago researching this condition. So, also before I start, I just want to ask you to please, if you can keep the questions to the end, because I might not be able to keep up with the comments. So I'll open the door for questions at the end. And as I understand, there are people tuning in to this presentation from all over the world. At the beginning, when I got invited, I thought it will just be the dental students in Jordan, but apparently it's spread a little bit more. So I know there are people tuning in from down under, from New Zealand and Australia. And for those people, I say kia ora, welcome. And for the people in Malaysia, I know some of my friends who are university teachers there and their students are watching. So, assalamu alaikum. And for everybody here in Jordan and the wider Middle East, ahlan wa sahlan. But before I jump into the lecture, I want to say a word from the heart to my students here at the University of Jordan, especially fifth-year students who are, inshallah, about to graduate soon, for whom Bren and I got to know very well over the past couple of years. And just wanted to say that, um, sorry, I'm getting some instructions from my wife. I'm too close to the mic? Okay. I'm being told I'm too close to the mic, so I just should move a wee bit further. I hope you do not get to see that I'm wearing pajama pants now. Okay, so a word to those students. We see you, we feel you, and as much as it pains us to know that you're quite upset about what's going on and about that you're left hanging, not sure how soon you can go back, and upset about all those plans that you've made not being fulfilled, your dreams of the graduation parties and all that being kind of ruined. So we feel you, and we are, as much as we are upset about that, as much as we are proud of you. We're proud of all your hard work. We're proud of your resiliency, your perseverance, and we're proud of the people you've become. And you are blossoming as amazing people, amazing dentists, and we are honored to call you our friends and our younger brothers and sisters. We know many of you on a personal level. Many of you spend their summer with us at our own private practice. Many of you have approached us as their older siblings, and we really love you and miss every single one of you. And inshallah, all of this will be over soon. So just hang in there, and all the best to you. Okay, so enough sentimental words. Now let's jump right into the lecture. And it will be a little bit heavy on the research part, but I'll try to make it light because I did a lot of work on this, and I do not want to miss all the great work we've done at the University of Otago. So part one, this is a two-part lecture because there's a lot to say. So buckle up and get ready for the ride. And this is the an important picture that we will come back to later in the lecture. It's the picture of my niece, actually, Yasmin Farah, and that was when she was first born. And you can notice the bruises on her face, the subcutaneous bleeding, and there's subconjunctival bleeding. She had her eyes closed in this picture, but this picture in particular is quite important. I'll come back to that, probably not in this part of the lecture, but probably tomorrow. But just remember it, and you'll later know why this picture is quite important. So if you notice, the title of the presentation was D3 group presents to you those broken down molars. What is the D3 group? Well, the D3 group is a group that I belong to, and D3 stands for developmental dental defects. So those are the 3Ds, developmental dental defects. And it's translational research and education network. The word translational is the key word, where we try to convey to the general public, the dental practitioners and researchers, the findings of our research, and try to make it easier for the lives of parents of children with MIH and other developmental defects to understand the condition their kids have and how to handle it in the best way, to answer some of their questions, and to help them in this sometimes difficult journey. We originally started in Australia and New Zealand, so that's the hub, but we spread wide world, and we have members in all over the world now. And we believe that by teaming up and pulling together, we can help get the developmental dental defects problems recognized better, understood better, and hopefully cared for better. This is our website, and we, in addition to sections for the practitioners and the researchers, we have sections for the family, where we usually refer the families of our patients to get more information on this condition here. And this picture of that little child holding the tooth is actually a book meant for kids. It's called Sam's Story, and it's about molar hypomineralization. And it explains to little children in words that they can understand everything about MH and why they have it. I'll be alternating between the acronyms MIH, molar incisor hypomineralization, and MH, molar hypomineralization. It depends on which part of the world you are, but both terms are perfectly acceptable. But we're kind of moving from MIH to MH now. Anyways, back to Sam's story. So I have this printed out copy in, well, copies in my practice, and I hand it out to children who have MIH. We have it in English and different languages. We are working on translating it to Arabic. In general, this website is a great resource for those of you who are interested to learn more about developmental dental defects. And it's, as I said, it's a worldwide group. and the, it's not just Australia and New Zealand now, it's all over the world. And a lot of members are all in the Middle East. And there are three of us here in Jordan. I'm the ambassador for the group, but we also have Dr. Fida Zawaide, who's currently in private practice, and Dr. Ala Batayne from the University of from Just University in Irbid. They are also members, and I encourage you all to become members, inshallah. And it's been an personal interest for me to study molar incisor hypomineralization or developmental dental defects in general. But not just me. There is a big group in New Zealand who are studying that, they are mainly at the University of Otago down south at the southern part of New Zealand. And we published a lot, as you can see, about developmental dental defects. We've studied it extensively. We published so many papers about this condition in particular. But we also worked, interestingly, with historic teeth. We worked with teeth that are thousands of years old, 4,000 years old, that suffered from developmental defects. So we've become quite experts on this topic, and this is why I want to talk to you about this topic in particular. And let's talk about enamel defects in particular now. So you can think of enamel. I want to explain it in a much easier way for most people to understand. So in general, there are two types of defects that the enamel can suffer from, either hypomineralization. So if this is a normal enamel or a normal person, hypomineralization will be a person with osteoporosis or an enamel with less minerals. It has the right amount of enamel, the normal quantity, but not enough minerals, and usually increased proteins. So less minerals, more proteins, but the actual thickness, the actual amount of enamel is still the same. Contrary to hypomineralization is hypoplasia. Hypoplastic enamel, you can think of it as dwarfism. So there will be regular concentration of minerals, but the amount of enamel is reduced. So the actual thickness of enamel is much, much less than normal enamel. So let's test ourselves if we can classify these coming pictures into hypoplastic or hypomin. What do you think about this? Look at the facial surfaces of these incisors, in particular this area here, the white chalky appearance. I'm sure all of you can recognize that this is hypomineralization because it's the appearance that is a little bit different. The amount of enamel is still the same, but there is less minerals, probably more proteins, which makes it hypomineralization. So this is hypomineralization. How about this tooth? Again, you can see some circles here in red. There is brownish areas and there are chalky areas. Again, the amount of enamel is still the same. The color is different, reflecting more porous enamel, less minerals, and more proteins. So this is hypomineralized. I'm sure you all guessed it right. On the other hand, those two incisors have what we call pitting enamel. There is a reduced amount of enamel in certain areas, but the present enamel is normal in terms of mineralization. So this is hypoplastic enamel. This tooth, when it first erupted, sorry, it had full cusps, full number of cusps, and it looked like a regular tooth, except that the color was different. But with repeated occlusal forces, repeated biting on that tooth, the cusps broke off and it lost some part of enamel. So originally it was a full amount of enamel, but with reduced mineralization, and that makes it hypomineralization, not hypoplasia. This is reduced amount of enamel, so this is hypoplasia. This is also pitting hypoplastic enamel. This is, I'm sure you can recognize it as different from all those pictures, and many orthodontists see that this is after debonding or removing the brackets, and this is demineralization. So this is acquired dental caries, and this is not a congenital defect or a developmental defect. This is an acquired demineralization. So this is basically dental caries. And what we see more often is not amelogenesis imperfecta. What we most often is molar incisor hypomineralization, or this picture, MIH. You can see the first permanent molars there in the back, discolored and broken down. So let me tell you about the story of Iman in relation to MIH. You probably remember Iman from, for those of you who attended my presentation on dental erosion. I also talked about Iman. And Iman is, when I first met Iman, she was a teenager, a Jordanian teenager who, just like us, had moved recently to New Zealand. This is her family and my family, and we became the best of friends in New Zealand. We met at the city of Dunedin, where we lived, and we became very, very close friends. And we toured New Zealand together. New Zealand, by the way, is an amazing country. It's my second home, and it has the most amazing landscape, the most beautiful cities. It has the best rugby team in the world. Sorry for for my Australian friends, but yeah, All Blacks are still the best. You can find penguins on the shores. So this is a regular site for us to see penguins at the shores of Dunedin. And the national bird is the kiwi bird. That's why people from New Zealand are called Kiwis. There are about 4 million people living in New Zealand and 60 million sheep. And yeah, it's just an amazing country. It's very far down south, as you can see, way, way down south. And this is the University of Otago, where I studied, where I worked for so many years. And it's an amazing place to study and work in. Well, back to Iman. And Iman was referred to us from the school dental therapist because of molar incisor hypomineralization. So this is her situation when she was first referred to us. You can see that her upper first permanent molars had restorations. Those restorations were repeated so many times, and they kept on failing. Those are her incisors, and as you can see, she had composite veneers on those incisors that were not so good looking, and she suffered obviously from MIH. But what is MIH? Well, MIH, according to the people who first coined that term, Verheim and colleagues, in 2001, Verheim and their colleague defined MIH as hypomineralization of systemic origin. So it's not hypoplasia, it's hypomineralization that can affect one or more of first permanent molars. So the original definition included first permanent molars, and to a lesser extent, the incisors. So it affects permanent incisors and first permanent molars, only those teeth. It doesn't always affect them all. It can affect the upper right first permanent molar, 1 6, 2 6, 3 6, all of those sixes. Sometimes the incisors are involved, and many times the incisors are not involved, but always first permanent molars plus minus incisors. The lesions are quite demarcated, which means that you can see their outlines very clearly. As you can see, there is a clear cut at the borders. Sometimes they present to you in atypical restorations, as we can see here. But always, the cervical enamel is spared. So the cervical enamel is not affected with this hypomineralization or what we call sometimes post-eruptive breakdown, as we can see in this tooth. Post-eruptive breakdown is basically when the tooth is so weak that it breaks down after eruption just from occlusal loads. These are other pictures of hypomineralized teeth, and you can see that it's not necessarily that all surfaces are affected. Sometimes it's the buccal surface, sometimes the occlusal, and any other surface can be affected. And it comes with a raft of problems. Sensitivity, pain, pulpitis, breakdown. But what makes it quite problematic is the fact that it's quite widely spread. So it affects 1 in 6 people worldwide. If we look at the first permanent molars affecting with MIH, there is 1 in 6 of us who are affected. And it's actually in most of the countries worldwide, it's the second most common reason for referral to pediatric dentists is MIH. If we take into consideration second primary molars that can also be affected, it becomes 1 in 5. So it's even more spread. So 20% of the population worldwide would have MIH. Here in Jordan, the prevalence is 17%, according to a study done by Dr. Zawaide and her team in 2011. The prevalence is about 17%, which is similar to the prevalence worldwide. To put things into perspective, 17% worldwide would mean around 900 million people currently affected by MIH. Just imagine that. 900 million people worldwide now suffering from MIH. That's the prevalence. The incidence or the number of new cases every year is around 17 million people. 17 million people worldwide every year present with MIH. About quarter of those 17 million people will need treatment of some sort because MIH is not always that severe. Sometimes it's just a little bit of chokiness that has no real effect. The person can continue to live with it for the rest of their lives like normal people. But there's about 25% of those people who will need treatment of some sort. So back to Iman now. Iman's chief complaint was sensitivity in her posterior teeth and unsightly fillings in her anterior teeth. And it's a well-known fact from research that people with MIH suffer from sensitivity 6 times more than normal people. So the odds ratio of people with MIH suffering from sensitivity is 6 times more. And sensitivity means that those people, unfortunately, cannot eat or drink properly. They cannot brush properly. They have increased dental anxiety and behavioral management problems, which means that a lot of those people will need nitrous oxide sedation, other sorts of sedation, and probably even general anesthesia. Another big problem with those with MIH, and I'm sure many of you have come across that, is the fact that it's really hard to achieve local anesthesia for those teeth. And that also, again, means more demand on sedation and more demand on general anesthesia. And this, the fact that these teeth are really hard to achieve local anesthesia for, made a lot of researchers wonder why. Why are those teeth more sensitive? And there were some studies that suggested some bacterial involvement. In other words, there are bacteria that can gain access into this hypomineralized enamel and causing sensitivity. So we decided at Otago University to study that hypothesis that there are some there is some bacterial penetration into these hypomineralized enamels. So what we did is what is called polymerase chain reaction, or PCR. We had samples from hypomineralized enamel, also samples from sound enamel, and samples from MIH enamel. So three types of teeth: MIH, caries, and sound teeth. And we looked at bacterial presence. So in other words, we extracted bacterial DNA, any bacterial DNA. We didn't care whether it was Streptococcus, Lactobacilli, anything. We just were looking for any bacterial presence in those teeth, in that enamel. And as you can see here with the yellow markers, or the yellow arrows, we were able to isolate bacterial DNA here and here, but this is not MIH enamel, this is caries enamel. We'd expect to find bacteria in caries enamel, but we could not isolate bacteria from MIH enamel. So, in other words, it's not bacteria that is causing the sensitivity. It's probably a combination of many things. Probably the fact that this enamel is porous, probably the fact that this enamel is broken down, and the fact that the dentinal tubules at a younger age are more open. So porous enamel, broken down enamel, and wide open dentinal tubules can probably mean or allow for stimuli to reach into the deeper dentin and the pulp much more easy and cause hypersensitivity. So how can we combat this sensitivity? This is an important thing clinically. There's some evidence, some weaker evidence, that fluoride works, whether it is toothpaste, whether it's mouthwash, varnish, gel. It does work to a certain extent in reducing the sensitivity. I see it in my own patients. It works to a certain extent. Unfortunately, not as much as we'd like it to, because those with severe MIH can still suffer. But it just means that we still have to keep working with fluoride. More recent studies have shown us that arginine-based paste, whether toothpaste or professionally applied paste in the clinic, those with arginine work much more nicer than toothpaste, than fluoride. In other words, arginine does block those dentinal tubules and reduce the probability of stimuli from reaching deeper dentin and pulp and causing sensitivity. And we have some stronger evidence with arginine as opposed to fluoride. Arginine-based toothpaste works nicely. There are other types of desensitizers that we can study. Research is still continuing, but so far arginine is the only one that has really proven effective. Many of you will be familiar with tooth mousse, especially those from Australia and New Zealand, because it was, I think, first introduced there. And tooth mousse is made of material that is called CPP-ACP, or casein phosphopeptide amorphous calcium phosphate. It's an extract from milk product, and it helps in mineralizing hypomineralized enamel and in remineralizing demineralized enamel, and also in reducing sensitivity in sensitive teeth. So there was a question which we asked ourselves: could CPP, ACP, or tooth mousse help in mineralizing MIH enamel? Does it work? And that led one of my colleagues, one of my good friends, Dr. Anuj Batra, to do his clinical doctorate to research this topic at the University of Otago. If you remember me saying at the beginning of the presentation that hypomineralized enamel will probably have increased amount of proteins. If we try to mineralize this enamel, hypomineralized enamel, we thought that this excess amount of proteins might not allow the tooth mousse to penetrate into this enamel and mineralize it. So is it probably a good idea to try to remove that protein before we attempt to mineralize it? In other words, if we treat hypomineralized enamel with sodium hypochlorite to remove that part of to remove some of the proteins, and then apply the tooth mousse or the CPP ACP, would it work better, or should we just go ahead and apply the tooth mousse directly? So Dr. Batra did the research, and what he found was that if we apply sodium hypochlorite, it will help in removing the outer proteins from the MIH enamel. And then if we apply the tooth mousse, there will be no increase in the amount of protein on the surface enamel. However, if we apply the sodium hypochlorite, it will result in weaker hypomineralized enamel. So in other words, we will make the hypomineralized enamel, which is already weak, already compromised, we will make it even weaker. That is expected because the sodium hypochlorite will remove the protein from between the crystals, making it weaker. But after we apply the tooth mousse, after we have removed the protein and we apply the tooth mousse, unfortunately, that did not make the enamel harder. So our attempt to remove the protein and then replace it with extra minerals with CPP ACP did not work. If we try to use CPP ACP directly without MIH, apparently it works nicer. If you look at the bottom arrow, you can see that the hardness or the mineral does increase in the outer surface of the hypomineralized enamel. We did a little bit more work, and which looked at the local anesthesia in hypomineralized enamel. Sorry, not more work, more looking into the literature. If we get patients with for whom we cannot achieve local anesthesia, we tried CPP, we tried desensitizer, we tried everything. What can we do? So you can use adjunct methods. Intraligamental probably can work. Intraosseous also work. There are other studies that show intraosseous supplemental local anesthesia to work. Surgical doses of ibuprofen or paracetamol 1 hour or half an hour before treatment also helps. Stepwise excavation, which means we don't have to remove all the broken down enamel right away in the first visit. Do it in several visits can also work. And pharmacological methods of behavioral management like sedation can also work. Now, moving on back to Iman. Iman's upper six, unfortunately, broke down. The composite broke down, which resulted in severe irreversible pulpitis. That is one of the common complications of MIH. And that is actually a common thing for composite restorations to break down with MIH teeth. Repeat restorations is one of the most problematic things for us as pediatric dentists with those teeth. And we know from research that MIH molars, whether primary or permanent, also can develop dental caries much more at a much higher risk and more severity of caries. So teeth with MIH lesions can develop caries, more likely to develop caries, and if caries does develop, it is more likely to be more severe. This, for me, as a researcher, was a bit confusing at the beginning, because when I was studying those MIH enamel or MIH teeth, what I did is I isolated some MIH enamel and I dissolved it in acid. I also had sound enamel that I dissolved in acid. So I had two types of enamel, one that is MIH, hypomineralized, and one that is sound. And I put both of these types of enamel in acid, TCA acid, trichloroacetic acid, and I looked at them dissolving. The sound enamel dissolves much, much faster than MIH enamel. This is expected because MIH enamel has a lot of proteins, while sound enamel has a lot of minerals. And the part that is going to dissolve much faster is the mineral part, not the protein part. So if that is true, how come MIH enamel is developing caries at a much faster rate than sound enamel or other enamel? We should assume it's more resistant. The problem with MIH enamel is actually it collects plaque much more easier than sound enamel. Remember those broken down teeth, those porous teeth, they can collect plaque much, much more. And that is the reason why they can develop caries at a much more faster pace and more severe carious lesion than regular hypomineralized enamel. So that is why MIH enamel is it causes all that dental caries. Sorry, it's not moving. Okay, so we looked at Iman's saliva, and as expected, it was her buffering capacity was low. It was on the acidic side, and that is just consistent with the more likelihood of, or with the fact that she's developing caries. There was this question that is a general question. Can we use fissure sealants in MIH molars? Is it safe to use them? And there is one important study that is published recently in 2017, and they looked at fissure sealant. They applied fissure sealant in normal teeth or normal molars and in MIH molars, and they followed them up for 18 months, so 1.5 years. And they found that they both had similar success rate in terms of retention and in terms of prevention from caries. So to a certain extent, yes, fissure sealants do work in MIH enamel, but you need to keep them under observation. It's a good practice to keep recalling the patient and checking those teeth. Anyway, Iman needed root canal treatment. But remember, in younger children where the apices are still open, we still can do partial pulpotomy. We don't have always to jump to full root canal. Partial pulpotomy does work. I want to talk a little bit more about repeat restorations. So there are different studies, several studies that looked at those repeat restorations. And one particular study in 2002 from Sweden that looked at 9-year-old children. So it looked at children who are 9-year-old who received who have MIH, and they noticed that 97% of those children, 9-year-old children, in that particular study, not always, but in that particular study, needed restorations. And the vast majority of those children with MIH needed repeat restorations. Of those children that they looked at, 97% needed restorations, but there is a big amount of people, or a big amount of 9-year-old children, 28%, that needed extraction. So more than a quarter of those children needed extraction, which is a huge number compared to the control in that group. 0%, none of the control group children needed extractions. So those people with MIH will need restorations. Their restorations are more likely to fail. They will need more restorations, repeat restorations, and they will need more extractions. Not to mention that actually the burden of cost on the parents or on the government for those children that will need repeat restorations. The children are suffering. They become anxious. They hate us. We frustrated with the number of visits they have to do, and it's just a nightmare. And as you can see here, with more examples, you can see that the composite looks absolutely ugly here, and you can see the broken down enamel here around the composite, and which is a disaster. So again, At Otago, we ask ourselves, why do these fillings keep on failing? Um, but we thought, let's take it one step at a time. Let's look at how weak this enamel is. Why does it keep on breaking? And there are so many ways to study this weak enamel. First, we thought we wanted to see, we knew that it is hypomineralized. Obviously, it looks chalky white, it looks brown, and that also tells us that it's hypomineralized. But we wanted to document that. We wanted to get an actual figure of how weak this enamel is. So what we did is we had few extracted teeth of MIH, actual MIH molars, and we studied them using something called micro CT scanning. I apologize for all this research, but hopefully you're finding it as interesting as I am. But the way to understand a new condition or a new thing is with research. Anyway, the micro CT scanner, we used it to study those MIH molars. And micro CT scanner is just like your regular scanner that scans the body, except that it takes very small samples and it assesses its mineral density. And it gives us a gray level picture. But in order to make it easier for to see the gray level picture that I saw, I changed the gray level picture into colored pictures. So the CT scanner can give you either a horizontal cross-sectional view or a sagittal view in the tooth. So this is a tooth within a MIH molar here, with a molar within MIH region. This is how it looks sagittally, and this is how it looks horizontally. And if you look at this index, the most important colors are a brown, which represents enamel, as you can see here, and also the green, which represents dentine, and the blue in the middle, which represents pulpal tissue. So this is a horizontal section, and this horizontal section is in the very cervical enamel. And because it's in the very cervical enamel where the enamel is not affected, all the enamel here looks brown. If we go a little bit higher, move more occlusally, we can start seeing here at the dentino enamel junction, the MIH lesion starts showing more and more, and it looks yellow. So the brown part is the sound enamel, the yellow part is the MIH enamel, and if we go more occlusally, you can see it here spanning the entire thickness of the enamel. We move more up, and now in this particular tooth, the MIH enamel is almost the entire circumference of the tooth and also the entire thickness of the enamel, as you can see here more and more. And at the very occlusal part, at the top of the tooth here, you can see that that cusp tip is actually spared. It's not affected. If we look at it in a sagittal section, we can see that it's wedge shaped, as you can see here. So it starts small in a narrow area close to the dentine enamel junction, and it fans out at the outer surface. And this is because it follows the incremental lines of enamel formation, or the lines of Retzius. And if we want to put a number from all those teeth that we studied, there is about 19% reduction in its mineral density. Obviously, it varies. Some have much less enamel. Some have more enamel, much less mineral, and some have more mineral. But in general, most of the MIH teeth or molars will have about 19% reduction in their mineral density. And that's not just my own study that found that. All the studies that looked at their mineral density came up with that similar number, 19 to 20%. But again, all those studies that looked at the micro CT scanning and the MIH molars, none of those studies found hypoplasia. We all found hypomineralization. There was no hypoplasia. To understand it more and to understand how weak this enamel is more, we wanted to study its mechanical properties. So we know it's weak because it's broken down or breaking down under normal occlusal load, but we did what we call nano indentation studies. So this is mechanical studies now. And I did that study at the University of Otago, but I did a substantial amount of that study at the Technical University of Hamburg in Germany. So I did part of my PhD there, and we looked extensively at how weak this enamel is. And just to make it quick, if you look here, this is the elastic modulus of a sound cervical part. And this is the hardness of that sound cervical part. And this is the mineral density of the sound cervical part. And they are all high, comparable to normal enamel. As we move to the defective part, to the affected part with the MIH, you can see a drop in the elastic modulus, a drop in the hardness, and a drop in the mineral density. All that is telling us that these lesions are quite weak. In fact, they are about 57 to 70% weaker or less hard than normal enamel. And there are studies that looked, a study from Melbourne that looked at particularly at why these fillings fail. And they looked at the micro shear bonding strength of composite to this MIH enamel. And what they found is that although composite can break down away or break away from enamel, most of the failures with the composite that is attached to the MIH enamel is actually cohesive in nature. In other words, the composite, while it can peel off MIH enamel, most of those failures is not because of that. It's because the weak MIH enamel right underneath the composite fails. It just breaks down. When the pillow under the composite breaks down, the composite itself will break off. And to avoid that, we are advising the dentist to extend their composite into the sound cervical part or other cervical part, sound parts of the tooth. By doing so, covering the sound enamel, we can achieve better results. But it's really hard to avoid breaking down the MIH enamel unless we remove all the defective enamel. So what is the best approach to actually restoring these teeth? Again, there are studies that looked at that, and we found, other people found that amalgam restorations are the restorations that fail the most. 61% of amalgam restoration failed, while 25% of composite restorations failed. If we cover those teeth with stainless steel crown, none of them had failed. So as a general advice, what we can tell you is, first, don't use amalgam because of the atypical shape of the lesions. And for smaller defects, it's probably wise to use composite. And by smaller defects, I mean very small hypomineralized lesions that are well circumscribed, not at the cusp tip, probably at the buccal surface, at a mesial surface, and you can remove all that broken down enamel without compromising the cusps, and then you can restore it with composite. The composite here would be probably a safe treatment as long as you remove all the hypomineralized enamel and extend your composite to the cervical enamel that is sound. But how about etching? Should we etch for the same time when knowing that there is increased probably proteins there? Well, my friend and colleague Erin Mahoney did some studies at the University of Sydney, and she etched that enamel for different times. And that honeycomb appearance that we get from etching with phosphoric acid could never be achieved with MIH enamel. So no matter how long we etch it for, we cannot achieve the appearance we want. So I still etch it for the regular 20 to 30 seconds that I do with regular enamel. But I can give you some clinical tips. First, try to remove, if you're doing a composite restoration, try to remove as much of the hypomineralized enamel as you can. Don't use glass ionomer or resin modified glass ionomer as your permanent filling. You'll be tempted to do that. It's an interim restoration. It's a weak restoration. You can only use it as a temporary restoration. And you can use sodium hypochlorite before etching. There are some studies that have shown it to do better job if you use sodium hypochlorite to remove the to remove the proteins before you etch. That will probably give you better retention. So that is probably a good idea. 5% sodium hypochlorite, but do not use sixth and seventh generation bonding agents. So the self-etching agents do not work as adhesives, do not work as well as the fifth generation and the fourth generation adhesives. So the rinse, then the etch, rinse, then put the adhesive systems work much better than those with self adhesive systems. We get just better results with them. As for moderate defects, I think that will probably be a little bit too much today for today, so we'll keep it till tomorrow. I do apologize for the length of the lecture today, but thank you for tuning in, and I want to thank my team. Sorry, that picture here looks a little bit odd because I changed it from PowerPoint to Google Slides, but this is when I thank my team at work for making my life and my wife's life easier. They are not just our team, they are our second family. We enjoy working with them daily. They make work enjoyable. They will make us want to go to work to be with our second family. So thank you to all of those people that we work with. And now I can open the floor to questions. Thank you for listening. And sorry for the long lecture and for the tremendous amount of research that I shared with you. So any questions, I'll be happy to answer. Very heavy topic, yeah. This is what happens when you ask a researcher to talk about their research. We just keep talking and talking and talking. So yeah, thank you so much. And with apparently no questions, hopefully tomorrow there will be more questions. I'll be happy to answer. And if you like to ask me through private texting, I'll be more than happy to answer. Thank you, everybody, and see you all tomorrow.